So we're going to give a more concrete example of how we're struggling through many of the issues that everybody else has raised. And this is a bit of a tag team talk between Jill and myself. I just want to acknowledge the support we've gotten from the NIH Transformative Research Program and the AHRQ Enhanced Registries Program. And just to motivate the discussion, I want to do it by talking about the participants in the chronic illness care system. This is Bianca, and the system of chronic illness care isn't working for her. She's 11, she's got Crohn's disease, and she's obviously in a lot of pain. That's the least of her problems. Without optimal treatment, she'll have stunted growth, possibly experience arthritis, and a significant risk of surgery. She can't go anywhere without knowing exactly where the bathrooms are, and normal childhood events like sleepovers are extremely difficult. It's also not working for Bianca's doctor, who we call Dr. Rohn. She's got a variety of treatment options, but the best evidence, our evidence that comes from clinical trials, can't provide information on what will work best for a particular patient. It's also not working for Bianca's mom. We call her Anna, because the care delivery model doesn't facilitate her participation. She's wondering about trying dietary modifications to see how best to control Bianca's symptoms, and she keeps up her eye on what's going on, but feels it's the doctor's role to come up with solutions. She doesn't really see the collaborative possibilities. And finally, it's not working for who we call Dr. Vincent Kapoor. He's a researcher interested in improving GI care, but he's faced with small and representative data sets and a lack of easy and productive ways to share data and increase the impact and reach of his research. So our project to develop what we call a collaborative chronic care network focuses on this question. What if we could harness, what if we could create a vastly better chronic care system by harnessing the inherent motivation, collective intelligence of patients and clinicians? If you think of Wikipedia or in science, how open sharing in the Human Genome Project in advance of publication dramatically accelerated the discovery process. These are examples of how the production of knowledge and information and know-how can be distributed over a large group of people. Yochai Benkler, who's a professor at the Harvard Berkman Center for the Internet, calls this form of production network-based or social production. In healthcare, networks for clinical research have been central to accelerating discovery, and networks of patients have served as potent advocates for more effective research management and greater investment, and now even in developing new knowledge. The model that we're presenting brings together all the stakeholders in the process, the patients, the clinicians, the researchers, to improve health outcomes as part of a learning health system. And our effort began in 2007 when the pediatric gastroenterology community, as part of the American Board of Pediatrics Maintenance of Certification program, organized a collaborative network called Improve Care Now that was dedicated to improving the health and lives of children with Crohn's disease and ulcerative colitis. These are some data from the centers that have enrolled more than 75% of their patients in the registry. The red lines show the variation in the monthly rates that would be expected by chance alone. And what you can see is that with no new therapies and no blockbuster drugs, the percentage of children with IBD is in remission has risen from about 60 to now over 75%. How did the clinicians do this? They did it by sharing. They were sharing knowledge, sharing know-how, sharing the work of figuring out how to improve the care delivery system. Every center has pooled their data, they've standardized their outcomes care, and learned from one another about how to get better results. There are currently 51 care sites, 425 physicians, more than 15,000 patients. And the Improve Care Now network is now working with, this is 30% of the patients in the country with IBD. Improve Care Now is working with the C3N project to evolve from a network that's focused primarily on clinicians to one that involves all the stakeholders. And to do this, we've concentrated on 4 main activities. The first is an ongoing focus on improving patient outcomes. The second is on building community. The third is on the effective use of technology. And the last is on developing the learning system, the use of system science, quality improvement, qualitative and clinical research together. During the design phase of the project, our ethnographic research that was conducted by our partners at the design firm LIBA identified the needs and goals of patients with this disease. Of particular interest for us were those patients who make a successful transition into adult care, whose treatment decisions are driven by personal preferences. They come to make IBD part of their lives and want to share what they've learned and give back. We reached out to engage these young people who are innovators and lead users in the community. And Jill Plevinsky, who will speak next, has made major contributions to designing and guiding and developing the system.
So very excited to talk to you about the work going on in this project. Also wanted to tell you a little bit about my very brief patient story. Happy to elaborate throughout the day, however. So I would in the introduction, I was diagnosed with Crohn's disease when I was 7. Growing up with a chronic illness, as a lot of you know in the audience, is not an easy task. But I was definitely very able to find comfort through support groups and Camp Oasis, which was a week-long camp for teens with IBD. And at that point was kind of my first patient community that I was ever a part of, but I didn't realize that we could do more than raise awareness and raise money until I became a part of the C3N project. So definitely just excited to be able to partner with physicians and researchers, and I've been playing a very active role in transforming care from the ground up. So there are a few reasons why I participate. Some of these may be familiar to some of the patients in the audience as well. No one likes to be sick. Like I said, having IBD is not easy. It's a difficult battle every day. I take medications daily, need to watch my diet, and as Peter mentioned, most of us always need to know if there's a restroom close by. And rather than kind of just be defeated by the experience, I chose to get engaged. I also trust my physicians. I have incredible faith in all of my doctors, and I believe that they can do everything that they can to ensure that I get the best care possible. But I know that they need my help in order to do that, and I want to help my doctor help me do that. So as also mentioned, I work as a research coordinator at Boston Children's, and it's kind of unrealistic to expect our physicians to give us the personalized care we expect if we don't help them do so. I witness every day how busy everyone is and how heavy caseloads can be, so I definitely know that this partnership is essential to the success of care. And with new technologies, like Ken was discussing, it's possible for patients to help. I also want answers to difficult clinical questions based on facts, not just hunches. With IBD, there's no one perfect treatment for everyone, and a lot of treatment decisions are made out of desperation. Improved Care Now allows doctors to really access what works for certain patients across the whole country and can help one another make decisions based on data. And I also want to help make pediatric healthcare participatory. This movement obviously has already begun in the adult world, but as a former now pediatric patient, the fact is children and adolescents need to learn these skills too, especially as new diseases are being diagnosed at younger and younger ages. I also don't want other kids with IBD to feel as if their care is beyond their control. A lot of anxiety and depression in kids with chronic illness results from this feeling that they're not in control of their own health care. And while some aspects of chronic disease are that way, it's important to remind young people that not everything is beyond their grasp, and that's the first step to becoming an engaged patient, in my opinion. So this is how we participate in C3N and Improve Care Now. As part of the grant, I joined the design team to imagine new ways to create more continuous and collaborative care. And it was at these meetings that we all realized it was really necessary to have a community building component. So I, along with other research team members, including physicians, researchers, nurses, and other patients, took a course by Marshall Gans, who was actually Cesar Chavez's community organizer and now professor at Harvard Kennedy School. And one of the keys to his community building success was distributed leadership teams, meaning that in order for a cause to kind of truly take off, you need to start with one centralized leadership team, develop leadership and foster that control within that team, and then let them kind of spread out to their local communities and start individual little communities all over the globe. It's a really nice way to allow leadership and ideas to flourish within a community, and this can definitely be applied to patients, physicians, researchers, and so on. So out of this framework, we decided to create a council of patients called the Patient Advisory Council. I'll refer to it as the PAC. There are pictures of some lovely ladies up here who are members of the council. Basically, this is a group of young people with IBD who were diagnosed as children and adolescents. And the major purpose of is to obviously foster leadership within the group. So we developed a patient scholar program where we allow these patients to attend our learning sessions, which involve all the clinicians from the Improved Care Now centers, so they can hear from patients at each learning session, which is awesome for us. And we also help the collaboratives develop tools as well. We actually used a match questionnaire to draw on their skills and expertise to kind of match them to projects within the C3N. So we decided on 6 projects. We decided on a mobile application to track patient-reported and passive health outcomes, an online social network, self-management tools, patient activation research, external communications as well. And once we did that, we have patients on just about every team working with doctors, researchers, developers to kind of really develop and answer what they think is important to the patient community. In my professional life, I see kind of firsthand how traditional clinical research and translational work is done, and the learning health system approach we use is very different. Patients are always asking me if they can see the results from studies personally, and the answer is often always no. But the way that Improved Care Now is different is that we use social media, Facebook, blogging, newsletters, things like that, to monthly share our data with the members of the database so they can see this lovely chart of the increasing remission rates within the population. And Peter's going to describe some of the technologies that we use to do this.
Thanks, Jill. So we've actually been building on some of Ken's work at Harvard using the I2B2 registry to create what we call a data in once system in which the same data that clinicians enter in the electronic health record for clinical documentation is repurposed for analytics, QI, and comparative effectiveness research. We've worked with the EHR vendors Cerner, Centricity, and Epic to create standardized templates for data entry like the one shown here from Epic. The data are extracted locally from the EHR database, combined centrally for research once data are de-identified. And the data are used to automate chronic care processes like pre-visit planning. This is a screenshot of the pre-visit planning tool that the clinicians use, and we also use it for population management. Data are also used to produce monthly quality improvement reports where the sites can see their performance and compare themselves with all the other sites. And the registry can also be used to generate new comparative effectiveness evidence at multiple different levels, at the level of the population, the care center, and the individual. And just in the interest of time, I'll just show 2 examples at the population individual level. So doctors and patients wondered if we could use the registry to compare the effectiveness of biologic therapy, which costs about $50,000 per year, with usual care, typically steroids and thiopurines, which cost about $3,000 per year. There'd never been a randomized trial in children to evaluate this question, and none was likely to be done in the future because of ethical concerns of withholding treatment shown to be effective in adults. So in a study that will be presented this spring, my colleagues Charlie Bailey, Marshall Jaffe, and Chris Forrest from the University of Pennsylvania used new methodology to simulate a clinical trial in, by taking advantage of over 1,000 patients in the registry and naturally occurring variation in the use of biologic therapy. This slide shows the cumulative percentage of patients in 2 groups who achieved clinical remission. The blue line is the patients receiving biologics. The red line is patients who didn't receive them for 2 outcomes, clinical remission and steroid-free remission. And so this information will be used by the network to help guide decision-making about the use of biologic therapies versus usual care. With the ability to collect data on a daily basis, we're also prototyping how to enable N-of-1 learning so individual patients and their physicians can work together to optimize their care. These are data from a college student with ulcerative colitis who had a colectomy when she was a young child, and she's been bothered by frequent nighttime stools and exhausted from getting up all night. On the y-axis, you can see the number of stools per night, and you can see the dates on the bottom. So she and her doctor, Jeremy Adler, who's a gastroenterologist at the University of Michigan Improved Care Now site, decided to start collecting daily data using an SMS text system. This revealed considerable variation. For example, there was a 6-day period when she went from waking up 3 to 4 times a night to waking up no times per night. And when she reviewed the data together with her doctor, she recalled that she'd been put on amoxicillin by her primary care physician for sinusitis. This reduction in symptoms happened again and led the two of them to decide, rather than testing steroids as the initial treatment, to test treatment with rifaximin, which is a locally released antibiotic. And this is work being done by my colleagues Ian Eslick at the MIT Media Lab, Heather Kaplan, and Dr. Adler, and a team of gastroenterologists. The regulatory aspects of data sharing in the network are complicated because the system involves chronic illness care and research together. Regulatory oversight about the use of PHI for the production of the automated pre-visit planning and population management reports is addressed through HIPAA notification and business associates agreement. These reports have patients' names on them so that they can be used to guide clinical care. It's not only inconvenient not to have a report with a code on it, it's also not safe. Because you need to be sure that you're giving the right treatment to the right patient. A federated IRB and consent are required for data to be used for observational research. The comparative effectiveness research that I showed uses a limited data set, whereas the intervention and health research uses full PHI, and there's consent for participation in those projects. I just want to touch on, because you all have talked about it, the complexity of the regulatory challenges. Virtually every physician in the network is extremely confused about PHI, about HIPAA. Many of them believe that there is no PHI shared outside their institutions. Buy-in for the federated IRB model that we're using is modest. About 38% of the centers have decided to rely on a central IRB, despite the fact that this is a low-risk project. And the effort to gain IRB approval and legal approval is pretty extensive. It takes 22 hours for our research coordinator per center, 82 emails back and forth the center, on average 3 months to get this through IRB and business associates agreement. The maximum is 7 months. And there's a direct impact of slower approval. It's fewer kids in remission. So in summary, the Improved Care Now Collaborative Chronic Network is an example of what we think is a learning health system that seeks to fundamentally redesign and restructure the research process by treating clinical care, operational improvement, and research as part of the same system, one that defines success based on better outcomes. And our hope is to bring the system to over 100 care centers and 50,000 patients, vastly increasing the number of children in remission. Our experience to date is that there are a number of challenges that we need to overcome. Bringing divergent groups together and overcoming the power, the language, the scientific and technical differentials is significant. We believe that investment in creating this idea of distributed leadership that engages and connects all the stakeholder groups has the potential to not only spawn more cooperative behavior, but also produce improved engagement and participation. The policy and organizational constraints impose significant transactional costs, time, money, and effort to collaboration, and the execution of the privacy, the ethical, and the regulatory documents is time-consuming, resource-intensive, and challenging socially. Investment in leadership by policymakers, we think, will be needed to test and disseminate new approaches to mitigate these costs, and these are questions that are amenable to empirical research. Collaborative networks like the Improved Care Now are with structured data in one's technology, standardized care, and systems for virtually real-time scientific learning amount to labs where we can test and learn our way into future systems that enable patients and families and clinicians and researchers to work together to help young patients like Bianca live gracefully with chronic illness. Thank you.
Thank you very much. We'll open it up now for questions.